Welcome. In this session, we'll be discussing about hereditary vitreoretinal and inner retinal disorders. Hereditary vitreoretinal degenerations, also known as hereditary vitreoretinopathies, are characterized by congenital vitreous anomalies such as coats, fibrils, and membranes within the vitreous cavity, early onset and progressive cataract, and a high incidence of rhegmatogenous retinal detachment. They also may have associated systemic and other ocular abnormalities. Most are autosomal dominant in mode of inheritance with significant variability in penetrance and expressivity, and so more than one family member needs to be evaluated to establish the mode of inheritance. And it is important to identify hereditary vitreoretinopathy, particularly in a child presenting with retinal detachment, for early management of the other eye as well as of the affected family members. Management considerations in hereditary vitreoretinopathies include correction of refractive errors and amblyopia therapy, with refractive errors occurring frequently in this group of disorders, surgery for early onset cataract, which is difficult because of lack of vitreous support, occurrence of glaucoma following cataract surgery, and frequent follow-up, early detection, and prompt management of retinal detachment, including prophylactic treatment in order to prevent the occurrence of retinal detachment in some of these disorders, and education regarding early detection and prompt reporting of sudden visual loss which occurs due to retinal detachment in this group of disorders. The first group of disorders we are going to discuss are chondrodysplasias with vitreoretinal degeneration, among which Stickler syndrome is the most common. These group of disorders occur due to mutations in various collagen genes and include 5 entities, among which Stickler syndrome is the most common. Stickler syndrome can be subclassified into 6 types, with each type being due to mutation in a different gene, and the collagen source genetic mutation cause Stickler syndrome include collagen 2, collagen 11, and collagen 9. We may recall here that collagen 2, 9, and 11 are the predominant types of collagen in the vitreous body, with collagen 2 constituting 75% of collagen in the vitreous body. Stickler syndrome due to mutations in collagen 2 and collagen 11 genes have an autosomal dominant mode of inheritance, and Stickler syndrome occurring due to mutations in collagen 9 genes have an autosomal recessive mode of inheritance. The other entities within this group of chondrodysplasias with vitreoretinopathies are also due to mutations in collagen 2 and collagen 11 genes, with Knobloch syndrome occurring due to mutation in the gene for collagen 18, which is present in basement membrane. Stickler syndrome, whether autosomal dominant or autosomal recessive, is completely penetrant with wide variability in expressivity. Extraocular features of Stickler syndrome include midface underdevelopment, as seen here in this clinical photograph, with Pierre-Robin sequence of micrognathia, macroglossia or glossoptosis, cleft palate, and upper airway obstruction, congenital sensory neural and conductive deafness, and mild spondyloepiphyseal dysplasia involving the spine, hip, and knee, along with precocious arthritis. Stickler syndrome type 5 has short stature during childhood but does not have midfacial anomalies. Ocular features of Stickler syndrome include congenital high axial myopia due to congenital megalophthalmos, vitreous anomalies including an optically empty vitreous which can be discerned only on slit lamp examination, with membranes and dot strands as seen here in these clinical photographs, radial perivascular retinal degeneration as seen here in these clinical photographs, which are also known as radial lattice degeneration and are very characteristic of Stickler syndrome, and a high incidence of retinal detachment from retinal breaks and giant retinal tears. These 3 photographs show patients with Stickler syndrome developing retinal detachment from giant retinal tears, with these being the portion of attached retina and these being the bare choroid. The cataract of Stickler syndrome is usually a quadrantic lamellar opacity as seen here in this clinical photograph, and glaucoma can occur from anterior segment dysgenesis. ERG, dark adaptation, and visual field abnormalities are not known to occur in Stickler syndrome, and visual function in Stickler syndrome patients remain relatively normal till cataract or retinal detachment develops. Type 3 Stickler syndrome due to mutation in collagen 11A2 gene does not have any ocular involvement type 1 Stickler syndrome due to mutation in collagen 2A1 gene, and type 4 Stickler syndrome due to mutation in collagen 9A1 gene have retrolental membranous vitreous as seen here in this clinical photograph, but no discernible gel in the vitreous more posteriorly on slit lamp examination. Type 2 Stickler syndrome due to mutation in collagen 11A1 gene have fibrillar or beaded vitreous throughout the vitreous cavity as seen here in this clinical photograph, and Stickler syndrome 456 due to mutations in collagen 9 genes have a lower incidence of retinal detachment. Like patients with Stickler syndrome, patients with Marshall syndrome have midfacial hypoplasia and deafness, with midfacial hypoplasia being more severe in Marshall syndrome as seen here in this clinical photograph, and these patients also have additional clinical features. Ocular features in patients with Marshall syndrome are similar to those in patients with Stickler syndrome. Patients with Nierst syndrome have short-rung dwarfism with kyphoscoliosis and enlarged joints with decreased motion as seen here in this clinical photograph, in addition to midfacial hypoplasia and deafness. And ocular features in Nierst syndrome are similar to those in Stickler syndrome. Patients with Knobloch syndrome have occipital encephalocele as seen here in these two CT scans, and ocular features in patients with Knobloch syndrome include, in addition to vitreous degeneration, retinal detachment and cataract with ectopia lentis, high myopia with severe myopic chorioretinal degeneration including macular atrophy as seen here in these clinical photographs, which cause loss in central vision in these patients, and also iris abnormalities with absence of crypts as seen here in these two clinical photographs, and iris transillumination defects. ERG in patients with Knobloch syndrome is also abnormal. Patients with Weissenbacher-Zwemuller syndrome have disproportionate shortening of humerus and femur, along with midfacial hypoplasia and sensorineural hearing loss. And ocular features in this syndrome include hypertelorism, various refractive errors and strabismus, but vitreous degeneration, cataract and glaucoma do not occur in this syndrome. Management of patients with chondrodysplasia with vitreoretinopathy includes management of systemic manifestation and prophylaxis for retinal detachment with Cambridge prophylactic cryotherapy protocol recommending prophylactic cryopexy of Stickler type 1 eyes with a single row of cryoapplication at the ora for 360 degrees. Goldmann-Favre syndrome, also known as enhanced S-cone syndrome, is an autosomal recessive disorder due to mutation in NR2E3 gene, which encodes a photoreceptor-specific transcription factor which plays a crucial role in development and maintenance of photoreceptors. Mutation in NR2E3 results in an excess of S cones at the expense of M and L cones, few if any functional rods, and disorganization of the retina. Patients with ESCS typically present in the first decade of life with nyctalopia with or without loss of central vision and hemeralopia, and the characteristic fundus finding in patients with ESCS is deep nummular pigment clumps at the level of RPE along with chorioretinal atrophy tightly distributed around the posterior pole and along the arcades. Other fundus findings in patients with ESCS include an optically empty vitreous with fibrils and membranes as seen here in this clinical photograph, and peripheral retinoschisis and foveal schisis, which are also found in patients with juvenile X-linked retinoschisis. Patients with ESCS typically have an hyperopic refractive error. ESCS has a pathognomonic ERG and is one of the three entities to have pathognomonic ERGs, the other two being bradyopsia and cone dystrophy with supranormal rod responses, which we have discussed in previous sessions. Since rods are absent in ESCS, the response to DA0.01 stimulus is absent in ESCS. The responses to DA3.0, DA10.0 and LA3.0 stimuli have similar simplified waveforms, all being contributed only by S-cones, and each of these responses are severely delayed and reduced in amplitude as compared to the corresponding responses in normal individuals. The response to flicker stimulus is also grossly delayed and reduced in amplitude because of the poor temporal resolution of the S-cones. And a characteristic of ESCS is that the amplitude of the flicker response is less than the amplitude of the A wave in LA 3.0 response, and the response to S-cone ERG shows an abnormally large S peak as compared to normal, with a highly attenuated L or M peak as seen here in this diagram. OCT in eyes with ESCS shows schisis cavities as seen here in these two OCT images, and in young patients with normal fundus appearance on ophthalmoscopy, fundus autofluorescence shows hypoautofluorescence along the arcades with an inner reading of hyperautofluorescence, and fluorescent angiography in eyes with ESCS does not show any leakage in the foveal area in spite of cystic appearance on OCT. Visual field examination shows absolute field defects corresponding to areas of retinoschisis, and also field defects corresponding to areas of pigments, and dark adaptation testing typically shows elevated rod thresholds. Histopathological examination shows excess melanin granules within the retinal pigment epithelial cells, and visual prognosis in patients with ESCS is highly variable. Familial exudative vitreoretinopathy or FEVR is an autosomal dominant condition due to mutation in genes encoding proteins which are involved in the WNT pathway, which plays a crucial role in retinal angiogenesis. We have discussed about FEVR in the session on retinopathy of prematurity, and as with retinopathy of prematurity, FEVR occurs due to failure of retinal vessels to vascularize the peripheral retina, particularly the temporal retina. And so the phenotype of FEVR is similar to that of ROP, but unlike ROP, FEVR is not associated with either prematurity or complex neonatal codes, and family members of patients with FEVR show evidence of disease such as peripheral avascularity and temporal dragging of vessels as seen here in this angiogram and in this color photograph. This photograph shows peripheral retinal detachment from peripheral neovascular proliferation in FEVR. Norris disease is an X-linked recessive disorder due to mutation in NDP gene, which encodes the protein nodin, which is also involved in WNT pathway. Norris disease is a blinding disease with patients having visual acuity of light perception or words, and on examination, the dysplastic retina appears grayish-yellow since birth. Retinal detachments typically occur within the first few months, as seen here in this clinical photograph, and later cataract, shallow anterior chamber, painful angle closure glaucoma, and phthisis bulbi can develop in these eyes. Wagner syndrome, Jansen's disease, and erosive vitreoretinopathy are autosomal dominant disorders having similar clinical features and associated with mutations in the same genetic locus on chromosome 5q, and so are considered to be the same entity. They occur due to mutation in the VCAN or CSPG2 gene, which encodes Versican, which is an extracellular matrix proteoglycan. Patients with Wagner syndrome present early in life with nyctalopia and develop loss of central vision later in life. The characteristic findings in Wagner syndrome include an optically empty vitreous on slit lamp examination, avascular vitreous veils at the equatorial retina as marked with these white arrows, abnormal retinal vessels typically showing nasalization in the peripapillary region, and progressive peripheral chorioretinal degeneration with pigmentary changes as seen here in these two photographs. Patients with Wagner syndrome also typically have temporal displacement of the fovea and thus demonstrate pseudostrabismus. Other clinical features of Wagner syndrome include moderate myopia and early onset cataract, but they do not have any associated systemic features. ERG shows diminished rod and cone A and B waves, and dark adaptation shows elevated rod and cone thresholds in eyes with Wagner syndrome, and visual field testing shows peripheral constriction of visual fields with development of a partial or complete ring scotoma. On OCT, some patients with Wagner syndrome show a partially detached posterior vitreous attached to the perifoveal region and arcing over the fovea. Snowflake vitreoretinal degeneration is an autosomal dominant disorder caused by mutation in KCNJ13 gene, which encodes a subunit of inwardly rectifying potassium channel located in the apical membrane of RPE cells. Patients with snowflake vitreoretinal degeneration may show coarse vitreous fibrils and peripheral vitreous condensation, and typically show Minute crystalline deposits appearing as snowflakes in the equatorial retina as seen here in this clinical photograph, and also a flat optic nerve head with a very shallow or absent cup. They may also show vascular sheathing and pigmentation in the involved area, but unlike Stickler syndrome, orofacial deformities and lattice degeneration are not found in patients with snowflake vitreoretinal degeneration. Visual field testing shows peripheral defects more pronounced in the superior visual field, and dark adaptation testing shows elevated rod thresholds later in the disease process. ERG testing shows reduced scotopic B wave amplitudes, that is a scotopic electronegative response. Autosomal dominant vitreoretinochoroidopathy or ADVIRC is caused by mutation in BEST1 gene, mutation in which also causes BEST disease and autosomal recessive dystrophinopathy, which we have discussed in the session on macular dystrophies. The characteristic clinical feature of ADVIRC is pigmentary changes in the peripheral retina from the equator to the ora serrata 360 degrees all around the fundus, with a discrete posterior border to this region at or posterior to the equator. Within this peripheral affected zone, retinal arteriolar narrowing and occlusion, retinal neovascularization, punctate whitish opacities on the retina, and choroidal atrophy can be found. But the posterior pole in this condition appears relatively normal. Other features of ADVIRC include breakdown of blood-retina barrier, which may manifest as vitreous cells and cystoid macular edema, and foveal atrophy, which can occur later in life in these patients. EOG is more severely abnormal than ERG in ADVIRC, and ADVIRC is not associated with either nyctalopia or retinal detachment, and visual prognosis in ADVIRC is relatively good. Autosomal dominant neovascular inflammatory vitreoretinopathy or ADNIV is caused by mutation in CAPN5 gene, which encodes calpain, which is a protease. Patients with ADNIV present in 4th decade of life with loss of central vision from CME and cataract. But prior to that, patients with ADNIV may manifest vitreous and anterior chamber cells, which are usually the first sign of the disease and can resemble any other autoimmune uveitis entities and may result in cystoid macular edema as seen here in this angiogram. Subsequently, peripheral retinal scarring and pigmentation and cataract develops in these patients, and following this, peripheral retinal arteriolar closure and retinal neovascularization occur, which may cause vitreous hemorrhage, tractional retinal detachment, and neovascular glaucoma. And the end stage of the disease is characterized by phthisis and no light perception. So this ultrasound shows phthysical eye, this photograph shows iris neovascularization, and this fundus picture shows vitreous hemorrhage. And eyes with ADNIV on ERG shows selective loss of scotopic B waves followed by reduction in scotopic A waves, and finally unrecordable ERG. Then we have two entities, X-linked retinoschisis and internal limiting membrane dystrophy, which are considered as inner retinal dystrophies. X-linked retinoschisis is an X-linked recessive disorder due to mutation in RS1 gene, which is exclusively expressed in photoreceptors and bipolar cells. This RS1 gene encodes a protein called retinoschisin, which is found on the outer surface of the inner segments of photoreceptors and on the outer surface of bipolar cells, and plays a role in cell-to-cell adhesion. Mutations in RS1 gene causing XLRS either interferes with tertiary structure of retinoschisin or secretion of retinoschisin. Prevalence of XLRS has been estimated to be between 1 in 15,000 to 1 in 30,000 individuals. Female carriers of XLRS nearly always have normal visual function, normal retinal findings, and usually normal electrophysiologic responses. Being hereditary, XLRS is bilateral but can be asymmetric in progression, and patients with XLRS present with loss of central vision in the first or second decade of life, following which vision deteriorates only very slowly and reaches a level of less than 20 by 200 only after 6 to 7 decade of life when macular atrophy develops. But sudden deterioration of vision can occur in these patients due to vitreous hemorrhage or retinal detachment. The characteristic sign of XLRS is foveal schisis and not the associated peripheral retinoschisis, and this foveal schisis is present in nearly all patients with XLRS and appears as small cystoid spaces in the fovea and spokewheel pattern of radiating stripe from the fovea, and so-called stellate maculopathy as seen here in this clinical photograph, which can be clinically detected in 70% of patients with XLRS. Peripheral retinoschisis as seen here in these two photographs occur in 50% of patients with XLRS, most commonly in the inferotemporal retina, and appears as a dome-shaped or flat elevation of a very thin and transparent layer of retina, which, unlike a fresh rhegmatogenous retinal detachment, does not undulate with ocular movements. And in XLRS, the splitting in the retina occurs within the superficial layers of the retina. Retinal blood vessels may pass through the inner or outer leaflets of the retinoschisis or from one leaflet to the other, and disruption of these blood vessels can lead to vitreous hemorrhage or hemorrhage within the schisis cavity. Following posterior vitreous detachment, the inner leaflet may settle down in its original position but does not regain its neural connections with the outer leaflet. Breaks can occur in the outer or inner leaflets of retinoschisis and can lead to retinal detachment when breaks occur in both the leaflets, and retinal detachment has been found to occur in 5 to 20% of patients with XLRS. Also, disruption of inner leaflet can lead to membranous remnants within the vitreous cavity, which are called vitreous veils. Patients with XLRS have high hyperopic refractive error, and other changes which may occur in peripheral retina of these eyes include retinal vascular attenuation and sheathing and pigmentation. An early onset infantile form of XLRS has been described, which usually present with bilateral very large bullous retinoschisis, often with vitreous or intraschisis cavity hemorrhage. Patients with XLRS have an electronegative ERG in which the B wave amplitude is reduced and is less than the amplitude of the A wave in the response to dark adapted bright flash stimulus, and this is very important to remember. Also, the A and B waves in the response to LA 3.0 stimulus are delayed, but unlike Schubert-Bonsheim CSNB, which also has an electronegative ERG and which we have discussed in the session on stationary inherited retinal disorders, in XLRS, the waveform of the response to LA 3.0 is maintained. OCT in eyes with XLRS shows schisis cavities, most commonly in the inner nuclear layer, but can also be present in the outer plexiform layer. Compared to cystoid macular edema, the central schisis cavities in the inner nuclear layer are more elongated vertically, and schisis cavities are present beyond the parafoveal zone. Visual field testing shows absolute scotomas corresponding to the zones of peripheral retinoschisis, and fluorescent angiography shows no leakage in the foveal region corresponding to the schisis cavities on OCT. In contrast to XLRS, eyes with degenerative retinoschisis do not have either foveal schisis or an electronegative ERG. Schisis cavities of XLRS have been shown to reduce with dorzolamide or acetazolamide, and surgery may be required for vitreous hemorrhage and retinal detachment occurring in these eyes. Prophylactic laser photocoagulation to prevent the occurrence of retinal detachment in these eyes should be considered and carried out very carefully, because it has been shown to increase the risk of retinal detachment in these eyes. And clinical trials for gene therapy in XLRS are underway, and we may note here that gene therapy for XLRS is administered intravitreally and not subretinally. Internal limiting membrane dystrophy, or ILMD, is the other inner retinal dystrophy, which is possibly an autosomal dominant disorder and is considered to be due to primary defect in the Muller cells. Patients with ILMD present with loss in visual acuity only after 5th decade of life, and ophthalmoscopy shows a characteristic glistening sheen as seen here in this clinical photograph, most prominently in the posterior poles and superficial to the retinal vessels. OCT shows schisis cavities in the inner retinal layers, which may also occur in the outer retinal layers later in the disease. ERG shows an electronegative response on dark adapted bright flash ERG, and fluorescent angiography shows leakage in late phase of the angiogram as seen here in this fluorescent angiogram, and this is said to be because of an abnormal capillary basement membrane, as retinal capillary basement membrane is contributed to by the Muller cells. To recap, hereditary vitreoretinal disorders are characterized by vitreous anomalies, refractive errors, early onset progressive cataract, and increased incidence of retinal detachment. Stickler syndrome belongs to a group of disorders called Chondrodysplasias with vitreoretinal degeneration. Stickler syndrome is caused by mutations in genes encoding collagen and can be either autosomal dominant or autosomal recessive in mode of inheritance. Extraocular features include Pierre-Robin sequence of micrognathia, glossoptosis, and cleft palate, sensorineural and or conductive deafness, and skeletal issues including precocious arthritis. Ocular features include optically empty vitreous with fibrils and or membranes, radial perivascular lattice degeneration, axial myopia, high risk of retinal detachment, but otherwise normal visual function and normal electrophysiological and dark adaptation responses. Goldmann-Favre or enhanced S-cone syndrome is an autosomal recessive condition in which there is an excess of S-cones, reduced number of L and M cones, and very few rods. Patients present with nyctalopy in first decade of life and may have loss of central vision later. Ocular examination shows a tight band of nummular pigmentation along the temporal arcades, peripheral and foveal schisis, and an optically empty vitreous with membranes and fibrils. The ERG of ESCS is pathognomonic and shows an absent response to DA 0.01 stimulus, delayed and reduced in amplitude but similar waveform responses to DA 3.0, DA 10.0, and LA 3.0 stimulus, all contributed only by S-cones, reduced amplitude response to photopic flickered stimulus, which is lower than the amplitude of the A wave in the response to LA 3.0 stimulus, and an enhanced response on S-cone ERG. Familial exudative vitreoretinopathy is an autosomal dominant condition occurring due to failure of retinal vessels to vascularize the temporal retina during development. It has a phenotype resembling retinopathy of prematurity, but unlike ROP, FEVR patients do not have a history of prematurity, and FEVR patients have family members with signs of the disease such as peripheral avascularity, straightening of retinal vessels, and temporal dragging of macula. Wagner syndrome is an autosomal dominant disorder in which patients present with nyctalopia early in life and develop central vision loss later. Ocular examination shows an optically empty vitreous with vitreous veils in the equator, nasalization of retinal blood vessels emanating from the optic disc, and peripheral chorioretinal degeneration and pigmentation. Juvenile X-linked retinoschisis is an X-linked recessive disorder in which patients present with loss of central vision by second decade of life. Ocular features include foveal schisis, which occurs in almost all patients, and peripheral retinoschisis, which occurs in only 50% of patients. Vitreous hemorrhage, hemorrhage within schisis cavities, and retinal detachment can cause sudden onset further significant loss of vision. An electronegative response on ERG is characteristic of XLRS, in which amplitude of B wave is less than the amplitude of the A wave in the response to dark adapted bright flash. OCT shows vertically elongated hyporeflective spaces in the inner nuclear layer of the foveal, and schisis cavities are also found in the outer plexiform layer and the inner nuclear layer of the foveal region, extending out to the parafoveal region and beyond. Thank you for listening.